All right, so we're going to talk about the goals of mechanical ventilation. And one of our first goals that we want to address is oxygenation. And the normal PaO2 for a patient is between 80 and 100 millimeters of mercury. And that is controlled by the FiO2 and the PEEP. And the PEEP is the positive end expiratory pressure. And that's essentially the amount of pressure left inside of the lungs when the patient exhales right before they take another breath in. Right at that moment between breaths, there's going to be some pressure left within the lungs, and that's the PEEP. And so the PEEP, or that pressure, the benefit of that is to keep the lungs or the alveoli from collapsing on themselves. That little bit of pressure splints open the airways, keeps the alveoli nice and pressurized and open, and that obviously facilitates the exchange of gas and including the absorption of oxygen into the bloodstream from the alveoli. So when you have atelectasis or collapsed alveoli for whatever reason, PEEP can be applied to increase the oxygenation of the patient by splinting open those alveoli that are collapsed. So oxygenation is our goal, and we can control that with the FiO2 and with the PEEP. Ventilation is the second goal. Another goal that we have as respiratory therapists, and the normal carbon dioxide level, which is controlled by ventilation, is 35 to 45. And we control the carbon dioxide level using the tidal volume if they're on a volume control mode of ventilation, or using the set inspiratory pressure if they're on a pressure control mode of ventilation. Either one of those two things. You can't have both. You got to be one or the other. So the other one that we use is the mandatory rate to control ventilation, and that's simply the amount of breaths that the machine is going to deliver to the patient per minute. So those two things, mandatory rate and either tidal volume or inspiratory pressure, are going to control ventilation. You know, the normal CO2 level is between 35 and 45, but depending on the disease process and severity, we may let that climb much higher. And, you know, if the risk of damaging the patient's lungs to maintain the carbon dioxide level in a normal range, you know, outweighs the benefit of that, then we're going to allow that CO2 to climb and try to preserve the lung tissue from damage. All right, so acid-base balance, or pH, is the third goal of mechanical ventilation for us to maintain, and that's controlled by the carbon dioxide level, which has an inverse relationship with the pH. So as the CO2 goes one way, the carbon dioxide or the pH is going to go the other way. Bicarb also affects the pH, and bicarb, unlike CO2, has a direct relationship with the pH. So bicarb goes up, that means the pH is going to come with it. Bicarb goes down, that means the pH is going to go down with it. So the fourth goal of mechanical ventilation is to keep the patient synchronous with the breathing machine, with the ventilator. Many things can cause patient ventilator asynchrony. Sometimes people assume that the patient just needs more sedation. As a respiratory therapist, you should endeavor to seek out other causes of patient ventilator asynchrony before defaulting to choosing improper sedation as the cause. So check your ventilator settings before assuming that the patient's not breathing comfortably with the machine because of inappropriate sedation. So which ventilator settings can cause patient ventilator asynchrony? Insufficient exhalation time is one. Let's say your patient doesn't have enough time to exhale. That's going to make them very comfortable. They're going to stack their breaths one on top of the other, and that can actually damage the patient's lungs and cause a significant amount of anxiety for them. If the flow setting is too low or too high, same thing. If the trigger sensitivity is not set sensitive enough, they won't be able to trigger a breath from the machine, and that can cause a great amount of asynchrony. If it's set too sensitive, they may get mechanical breaths when they don't want them. Inspiratory time can also be set inappropriately and cause asynchrony. If they want to exhale, but the inspiratory time is too long, set too long, then that's going to cause a tremendous amount of distress when they have to forcefully exhale against the breath coming from the machine. So these are all things to consider. Once you've ruled out ventilator settings as the cause of patient ventilator asynchrony, then you can consider, well, maybe they're not appropriately sedated, or they're having some pain. But first, check the ventilator settings. All right, so the fifth goal of mechanical ventilation is to do no harm. We don't want to cause any trauma. We don't want the patient to get any infections. We want to use the aseptic technique when we're suctioning the patient. We want to use appropriate tidal volumes so that we don't overventilate the patient's lungs and overdistend them. So we got to be real careful. We don't want to do any more harm to the patient than they're already going through in their current situation. Okay, and then the final goal of mechanical ventilation is ventilator liberation. We want to get them off the machine, and we're going to talk more about that in a later module, but that is the ultimate goal.